the WHO Africa Media Briefing. My name is Dr. Mary Stephen. Today, we will be focusing on the latest disease outbreaks and how cyclone is affecting people's health in the region. We will also be talking about the region's progress regarding stopping TB. First, some housekeeping. You can listen to the press briefing in either English or French. To do this, please go to the bottom right-hand corner of your screen, click on the interpretation icon, and select your most preferred language. Vincent, can you please explain in French?
Bonjour et bienvenue à tous à cette conférence de presse de l'OMS. Vous pouvez choisir de suivre cette conférence en français en cliquant sur l'icône interprétation en bas à droite de votre écran et en sélectionnant donc la langue de votre choix. Over to you, Dr. Mary.
Merci beaucoup, Vincent. And now joining us here from Brazzaville is Dr. Mashidisho Moeti, the WHO Regional Director for Africa. I will hand over to Dr. Moeti to introduce our panelists. Good morning and welcome, Dr. Moeti.
Good morning. Thank you very much, Mary. So I'd like to wish a very good day, bonjour, bon dia, and a warm welcome to all our journalist colleagues who are joining us for this press conference. Today, I'd like to discuss the humanitarian situation caused by Cyclone Freddy in Malawi, Mozambique, and Madagascar, and Africa's progress on ending tuberculosis. I'm delighted to be joined by Dr. Charles Mwansambo, the Secretary of Health in the Malawi Ministry of Health, and Dr. Norbert Njeka, the Director of the Drug-Resistant TB and HIV Program at the National Department of Health in South Africa. A warm welcome to both of you today, and thank you very much for having joined us. In our last edition of a press conference on the 2nd of March, I shared that after I left Mozambique, tropical cyclone hit Madagascar and was sweeping back to southern Mozambique. And on May the 13th March, it made landfall in Malawi. The cyclone has left an appalling humanitarian situation in its wake. More than 300 health facilities, including university hospital centers, have been destroyed or flooded in Madagascar, Malawi, and Mozambique, leaving communities without adequate access to health services. The extensive damage, flooding, and torrential rains have affected more than 1.4 million people in the three countries and stretched the capacity of health systems. Almost 1,400 people have been injured in Malawi and Mozambique, while 282 are missing in the former. In Malawi, 13 districts and 2 cities have been hit, including the city of Blantyre. And in Madagascar, 10 out of 23 regions and 34 districts are affected, while Mozambique reports casualties from 5 provinces. And as of the 20th of March, 605 deaths, unfortunately, have been reported cumulatively. Houses, schools, roads, and other infrastructure have been destroyed or damaged, and swathes of inundated farmland raise the fear of malnutrition and the development of diseases and chronic health conditions. Dr. Mwansambo will no doubt speak more about the ongoing response in Malawi. Increased and concerted humanitarian assistance is needed to support the affected populations to cope and eventually recover from the disaster. We at WHO have provided almost $8 million in support and deployed over 60 experts to the affected countries to support the emergency response. The cyclone's devastation has raised public health risks, including the increased spread of cholera, malaria, vaccine-preventable diseases, even COVID-19, and malnutrition. And of course, support for trauma and mental health is equally needed. We've shipped nearly 184 tons of laboratory, treatment, and other critical medical supplies to boost the cholera outbreak response. And we've decentralized this response operation to hotspot districts. We've also trained more than 1,500 health workers in the 3 affected countries on disease surveillance, on clinical care, community mobilization, to secure public support for their response. A total of 12 African countries are currently experiencing cholera outbreaks, and in some part of the region, the ongoing outbreaks are exacerbated by extreme climatic events and conflict that have increased vulnerabilities, mainly as people move away from their normal places of home. Turning now to TB, tuberculosis. On this World TB Day, the African region has achieved a 22% decline in new infections since 2015. Through our normative and supportive role as WHO, technical support, advocacy, and effective partnerships, the African region is now on the threshold of reaching a 35% TB death reduction. There's been a 26% drop in TB deaths between 2015 and 2021 in the region. 7 countries, Eswatini, Kenya, Mozambique, South Sudan, Togo, Uganda, and Zambia, have attained a 35% reduction in deaths since 2015. So we've shown that it is possible to reach and even surpass the first milestone of the NTB strategy, fixed at a 20% reduction by 2020. Over the past decade, we've seen a notable progress in Eastern and Southern Africa. High-burden countries like Ethiopia, Kenya, Lesotho, Namibia, South Africa, Tanzania, and Zambia have reached or surpassed the 20% target of reducing new TB cases. Our member states are increasing the uptake of new tools and guidance recommended by WHO, resulting in early access to TB prevention and care and better outcomes. The use of rapid diagnostic testing has increased, improving countries' ability to detect and diagnose new cases of the disease. The awareness campaign we lead on TB case finding and tracking is equally paying off. Nigeria, for example, managed to significantly increase national TB case finding by 50% in 2021 using innovative approaches such as the adoption, deployment, and expansion of newer diagnostics in daily TB treatment, the use of digital technologies, community active case finding, and public-private mix initiatives. We do still face some challenges, notably delayed diagnosis and testing, since 40% of people living with TB did not know their diagnosis or the disease was not reported in 2021. Moreover, an estimated 1 million people are living with TB in the region, yet to be detected. There's a well-known link between TB and HIV. Approximately 20% of people newly diagnosed with TB are also living with HIV infection. And we are fighting multi-drug resistant TB. In the African region, just over a quarter of all people living with multi-drug resistance are receiving the appropriate treatment. And Dr. Njeka will no doubt discuss the ongoing efforts and challenges around this in his country. TB, such an old disease, kills more people than any other infectious disease. Nevertheless, new drugs, vaccines, and tests offer hope of ending TB in our lifetime. The UN General Assembly will hold the second high-level meeting on the fight against TB on the 22nd of September 2023. It'll provide a global platform to strongly articulate the TB problem and what needs to be done to end it. It'll shine a light on the plight of TB patients and the disease's impact on economies, expand advocacy around TB using diverse leading voices, and mobilize the needed political commitment and financial resources to end TB. Once again, thank you very much for joining us and spreading information on health, and a special thanks to our guests, and I look forward very much to our discussions today.
Thank you very much, Dr. Moeti. Thank you for that elaborate update on the outbreaks, the cyclone, and also the interesting progress we have made in the region regarding TB control. Now turning to you, Dr. Charles Mwasamba, can you tell us how Malawi has been affected by the recent storms and how you are responding? Dr. Charles?
Thank you very much, Mary, for your question. As Adi has mentioned, Malawi is one of the 3 countries in the region that has been badly affected by the Cyclone Freddy. The tropical cyclone induced torrential rains between the 11th and 13th of March, and these rains resulted in floods and mudslides in 14 districts in Malawi. That's almost half the country, because Malawi has 28 districts. And due to that severity, our state president declared a state of disaster in the 14 affected districts. And during that time, he appealed for both national and international support for the affected people. And at present, we're in a period of national mourning for 14 days. In the immediate aftermath of the cyclone, the severe loss of life, injuries, and property damage of varying degrees. And we continue to report that on a daily basis. And in terms of human costs, as of the 22nd of March, which is yesterday, we'd lost 511 people who were confirmed dead, and many have been injured as well. As of yesterday, they're close to 1,300. And we still have some that are missing, about 533. But that figure continues to go up because the floods took away quite a number of villages. Some of the villages are completely washed away. And at present, we have a total of over 500,000 internally displaced people. And for now, we're still continuing to search and rescue the affected community. Some of them, because of the distraction to the roads, were unable to access some of the places. At present, we have 576 camps that are set up to accommodate these internally displaced people. We are distributing water, sanitation, and hygiene kits, plus also water quality tracking, and then also we're installing mobile latrines in most of these people, because along with the houses, most of their wash facilities were also washed away. We're also distributing food items thanks to a number of friendly countries and organizations that have helped us so far. And of course, there's also the protection services to minimize the risk of sexual violence and other forms of violence resulting from overcrowding. As a sector, we're also providing clinics in these camps, and for those that faraway places, we're also organizing some mobile clinics. But the challenge is that some of the roads and bridges were cut. I mean, we have in excess of 40 roads where the roads and bridges were washed away. So that's making access to some of these areas almost impossible. I need to thank the governments of Zambia and Tanzania, and also the UK government, among the many other governments that have assisted us with rescue helicopters and boats that have helped us get to some of these people. In terms of coordination, this has been coordinated in the president's office, and the president himself is actively involved with a response. And we have a department of disaster management affairs, which is in the office of the president that's leading this response. At present, we are in the process of establishing the full extent of this. All the government departments have been tasked to make a detailed assessment of their sectors, and this will be finalized this week. And as soon as that information is available, we'll develop a response plan which government and partners will work on and call on the international team to support. There are some huge gaps in terms of shelter and food and medical supplies that I would call on the journalists and international partners to help us with. Because we knew this cyclone was coming, but we didn't imagine that it would be of this magnitude. Thank you very much. I'll stop there.
Thank you very much, Dr. Charles. And now we will turn over to Dr. Norbert Njeka from South Africa. Can you tell us what challenges South Africa face in the fight against TB? Dr.
Yeah,
Norbert?
thank you. Thank you so much, Program Director. Thank you for the invitation. Maybe just to also inform you that since we last met, I recently got redeployed to a position of Chief Director, TB Control and Management for TB Control in South Africa. So what we're really facing here is that, like many other countries in the world, in South Africa, we've been struggling with finding all people with TB. And even when we find them, linking them to care becomes the next challenge, retention in care. But also because of our biomedical mind wanting to treat acute diseases, prevention has not been really a priority over the years. Those are the things that we've been struggling with over the years, but COVID made it worse in that it made us now to start testing fewer patients as we diagnosed fewer patients, and obviously fewer got successfully treated because death rate increased as well as loss to follow-up. Now, what we did was to come up with a TB recovery plan to improve finding missing people with TB. Although we acknowledge the fact that screening is important, you got to treat people when they have symptoms. Our prevalence survey, TB prevalence survey, picked up that many people were having lesions in their lungs wherever when they didn't have any TB symptom. So we then made an exception to say people with high risk, those who are close contact of confirmed TB individuals, those who have HIV or those who have recently finished TB treatment would be tested regardless of symptoms. And this seems to be working for us because we then been able to increase testing, and we picked up more people during this year, that the last year that when we started that. We brought in something critical. We started sending SMSs to each and everybody with TB in the public sector. Although many people didn't give us their cell numbers, but to those who received, we managed to link them to care. And we believe that probably that contributed to us putting on treatment more patients than our target for the past year. So that's a critical thing we did. Regarding retention in care, we've been wanting to introduce shorter regimens. It's still work in progress. We're also wanting to have a central distribution of medicines to patients' homes. This is still work in progress. We're excited that our guidelines on TB prevention therapy have been approved. Finally, we're able to scale up this activity moving forward. Hopefully, this will help us to further decrease TB incidence and find more people, close the gap between those we find and those that start treatment. So that's really in a nutshell what is happening. But more important, we also want to improve education, public education and advocacy and data systems, because we realize that we're struggling with data systems as well. So that's in a nutshell what we're doing about TB in South Africa. Thank you.
Thank you very much, Dr. Njeka. And now that we have heard from all our panelists, it is time, you journalists, to ask your questions. To do this, please use the Q&A function on the Zoom platform. Tell us your name and the name of the media organization you represent. If you like to go live, indicate in the Q&A as well. We have additional experts to also answer your questions. First, we have Dr. Fiona Baraka, the team lead for emergency response. We have Dr. Jamal Ahmed, polio coordinator. We have Dr. Michael Gassana, team lead for tuberculosis, and Dr. Solomon Wade Sadiq, health emergency officer. So I would like to start while we wait for those that would like to ask their question live. Okay, Paul, are you ready?
Yes, I'm ready. And good
right.
morning, and thank you very much for taking my question. I have two questions. The first one goes to Dr. Moeti. Anybody that can comment on last week's announcement of an outbreak of circulating poliovirus type 2 in Burundi, and we also learned similar thing is happening in DRC. The new vaccine, one of the reasons why the current vaccine, one of the reasons why it was introduced was to potentially reduce the risk of circulating poliovirus type 2. So with these developments in Burundi and DRC, possibly what is being done to track other similar development in other places where the vaccine is being used in Africa, and what is the next game? What is the next strategy towards actually ending this the threat of circulating poliovirus type 2? Then my second question is on tuberculosis.
Paul, sorry. Paul,
yeah?
we are finding it difficult to hear you. Can you speak a bit louder, please?
Okay, the second question that I have is on tuberculosis. Every now and then we get reports of better treatment, improved treatment protocols. So I'd like to know, probably looking at the situation in South Africa and insights from other countries, what is being done to ensure that these treatment and prevention strategies that the science ecosystem is coming up with, that the WHO is also recommending, are quickly being integrated into national tuberculosis programs by not just focusing on treatment, but also putting attention to prevention strategies also. Thank you very much.
Okay, thank you, Paul. So for your first question, go to Dr. Moeti on the issue of polio, and then Dr. Jamal will complement. Then we go to Dr. Njeka for the question on TB in South Africa.
Yeah. Okay. Thank you very much for those questions. I think first for the novel polio type 2 vaccine, yes, indeed, we are aware of the cases in the two countries that you have cited in Burundi, and we are working with the national authorities and the programs, as we have done in other countries, to contain these outbreaks. I think our expectation indeed is that even though we do have these cases, and we are working quickly with the countries to contain the spread of this outbreak, we are expecting that this new vaccine will cause fewer cases than we have seen with the old version of the vaccine. I think we always need to learn more about new tools as they're being made available. I don't believe any tool is perfect, but our expectation is that with what we have learned in the past and with the kind of mobilization around these campaigns that are being carried out, we'll be able to contain these outbreaks very quickly. In terms of the TB, how to improve access to new treatments, and indeed how to have an impact, I believe that Dr. Njeka said it very well. And by the way, congratulations, Dr. Njeka. We were unaware of the change in your title, and we look forward to continuing to work with you in your role. I think you emphasized very well that even if we have access to improved tools, what's very important is to cover the gap in the number of cases that are not detected early enough, and the kind of interventions and strategies that are being deployed in South Africa that were shared to go after looking at cases, look at those who are highest at risk, screen them, and actively seek cases is what then will optimize the benefit from new tools like the new drugs that have been developed. So these are the kind of strategies, I think, which are very well outlined by Dr. Njeka, that we need to be scaling up in all the countries in order to cover that gap of undetected cases, which then opens up the possibilities for treatment and for bringing the situation under control. So perhaps my colleagues might like to complement, as has been indicated by Mary. Over back to you, Mary.
Thank you, Dr. Moeti. Let's start with you, Dr. Jamal. on the polio question, if you have anything to complement.
No, thank you so much, Mary. The sound system was a bit challenging, but I did get the question. For the novel vaccine, just to note that just the type 2 wild poliovirus was eradicated in Africa a long time back. We withdrew the TOPV, which is and we were using monovalent OPV2 for a while. Now, with the introduction of the novel OPV2, we have seen a 20 times reduction in the number of new emergencies within the African continent. So these new emergencies are expected, but they are much, much, much fewer than we've been seeing with the monovalent. And for Burundi, for DRC, already we've had the multiple calls with the countries affected, and they are already planning to do immunization campaigns up to 3-4 over the next 3 to 4 months. By June, we should have had responses not only in Burundi and DRC, but also in other geographies that are at risk. And we are in constant contact with the countries. So thank you so much, and back to you, Mary.
Thank you, Dr. Jamal. Dr. Njeka, do you want to compliment on the TB?
Yeah, thank you so much. I'd like to thank the World Health Organization for what's happening now. I've been in TB for a while, and I was very frustrated my first 6-7 years in TB because guidelines will take forever, 7 years, 6 years to be changed. Now people are complaining. They say, no, there are too many changes, but we're enjoying these changes because we used to be frustrated in the past. The WHO is really working hard to find evidence, and I think even COVID vaccine is evidence that quality doesn't have to take too long. You know, we can be fast in all this. But regarding implementation of this new regimen, what I can add also is that in South Africa, we can't undermine the role of civil society. Civil society keeps government on its toes, and it's quite exciting to see what is happening. There is political commitment indeed, and these are things that that are helping, but also what should be strengthened is high-level discussion between WHO and country leaders to remind leaders their role of taking care of people. If they give us enough TB drugs, we'll cure patients, and those patients will go vote for them. I think this message should be clearly transmitted out there, and really we're all doing this, but leaders have a role to play, civil society, and the doctors in the field, we come up with policies to guide them appropriately. I believe Global Fund is also helping with funding in many countries, high-burden countries at least. So we need synergy around all these key stakeholders. Thank you.
Thank you very much, Dr. Njeka. And this next question is coming to you first, Dr. Moeti, and Dr. Fiona could prepare to complement. The question is coming from Lauren Lefer from Gizmodo in the US. Is the Marburg outbreak in Tanzania believed to be all linked to the earlier outbreak in Equatorial Guinea? Dr. Moeti?
Yes, thank you very much for that question. We don't have evidence yet of any link between the Marburg outbreak in Tanzania, which we believe was initially, if you like, notified on the 16th of March, and the outbreak in Equatorial Guinea, of which some cases were announced middle of February. But there are tests going on. There is genomic sequencing being carried out in both countries now that will enable us to be able to see if these two outbreaks are connected. I think, of course, we know that the world is interconnected in many ways. The likelihood is not that high. I think what we can say about these two outbreaks, first of all, is very much to appreciate the rapidity with which the government in Tanzania announced the outbreak. As I said, there was first observation of this illness and some people having fallen sick and dying around the 16th of March. And yesterday we had announcements by the Minister of Health, by the WHO representative, and by the head of state of this outbreak of Marburg disease. And we have actions going on to support the governments in both countries to bring those outbreaks under control. And we will be able to see if there's a connection between them as we do further laboratory testing.
Thank you very much, Dr. Moeti. Dr. Fiona, any additional inputs on this?
Thank you, Barry. I think the RD has mentioned the detailed investigations and the genetic sequencing will be able to give us more information on what the possible source was or the closest link of the viruses that we are seeing in these two countries. Some initial work had started. As you know, the Equatorial Guinea outbreak started earlier in February, and the initial genetic sequencing did indicate that there was a closest link to virus detected in fruit bats in Sierra Leone. But the investigation still continues. And for Tanzania, this was notified 2 days ago. So the teams are actually in the field trying to conduct an investigation. All we know is that, or what we know so far is that that index case did come from an island in Lake Victoria and had traveled to Bukoba District Council, which is where then treatment was sought. But we do not have further details as to the investigation, which should be able to answer that question. Thank you.
Thank you very much, Dr. Fiona. And now I turn to Janice Q. Are you ready to ask your question live?
Hi, yes, please. I was just wondering, we've had a story out today on Ugandan lawmakers approving legislation with harsher penalties for violating laws that basically outlaw homosexuality. And amongst that list of documents is offenders that are HIV positive will attract harsher punishments. The punishments are pretty harsh. I mean, it includes death and life imprisonment. I was wondering if there is amongst the health community and the WHO, if there is a grave concern that this is going to drive people who are HIV positive away from treatments, if it's going to make it more difficult for people to seek treatments, if there's concern that this is going to predominantly affect young people in that country, and even if the risk of spread of this pandemic, which it still is really, HIV, if the risk is raised, not just within the country, but regionally.
Thank you, Janice. Dr. Moeti?
Yes, thank you. Thank you very much for that question. I think that the HIV pandemic response over the decades that it has occurred has given us many lessons about criminalization and its impact on public health interventions to bring under control such an infection as HIV. And we know that in quite a few cases, quite a few countries, work has been done to decriminalize in the legislation the transmission of HIV. That was the case at the beginning of this pandemic. We also know that it's very important for people of all profiles, of all communities who are vulnerable to infections to be able to have access to care and treatment. So we do not know yet the details of this legislation that has just been adopted by the parliament in Uganda. We will study this legislation, but I think we know already from previous experience that what is very important is for people to be able to freely have access to treatment and care. Excuse me. And in some cases where this treatment for groups that were somewhat stigmatized was being organized at the community level. It's very important that these access to services continue. I think Dr. Njeka made reference to the importance of civil society in relation to accessing tuberculosis treatment. We know that in order to ensure access to treatment, we have multiple opportunities in the public sector, facilities in the private sector, and very much the role of communities is critical. So our initial reaction would be that we would like to continue to have this possibility of community intervention to make sure that people who are living with HIV and who are at risk of HIV get access to treatment and prevention interventions.
Thank you very much, Dr. Moeti. Can we go to Patrick? Are you ready to ask your question live? Patrick? Okay, so let me take this question and then I'll come back to you. This question is from Pauline Cairo from The Nation in Kenya. How does drug resistance compound the problem of TB control in our region? And what do the numbers look like? I'll start with you, Dr. Moeti, and then Dr. Gassana can complement.
I think I'll just say briefly that, of course, drug resistance does play a very important role in exacerbating the situation. It limits the effectiveness of the medication that is available. It therefore drives the need for new development of new medications, and it can lead to the failure of treatment, the continuing spread of the disease at all levels. So it's a very important factor that needs to be addressed in the work on addressing TB at the global level and very much in the countries of our region. So it's something that deserves all the investment, all the intervention, and ensuring part of the emergence of drug resistance is linked to compliance with treatment. We have to ensure that once people are diagnosed, they take treatment as required and drug resistance is minimized. So drug B, as has been revealed by WHO, is one of the big challenges that we're facing now with this long, as I've indicated, TB is a disease that has existed over many years. It's been very much driven up by HIV in our region, which has had such a serious situation. So that's what I'd like to add. So perhaps Dr. Njeka might like to add specifically from the experience and the work that they are doing in South Africa on this.
Thank you, Dr. Moeti. Okay, Dr. Njeka, if you have additional reflections, and then Dr. Gassana.
Yeah, thank you so much. Yeah, drug-resistant tuberculosis is a tragedy. It's a big problem. I think we've had a court where you have. I remember when I joined as a director, drug-resistant TB, the cure rate for XDR TB, for example, was 0%. We struggled to bring it to 9%, and very difficult to see a lot of people die. And you spend a lot of money. We used to spend 300 times more on drugs to treat one XDR than the rest of ordinary TB, and with a chance of curing like 10% by then. Now things are improving. So I agree with Dr. Moeti. Drug-resistant TB numbers are few, but they consume a lot of money, a lot of effort, and your outcomes are not guaranteed. First chance to treat TB is the best chance. We need to find people early enough and treat them early. If you miss that early opportunity, even if you come up with the best drugs later, it's a problem. You're not guaranteed success. Thank you.
Thank you very much, Dr. Njeka. Dr. Gassana?
Okay, thank you very much. As RD and Dr. Njeka mentioned, drug-resistant TB poses a major public health issue to patients, their families, and also the public, the public health system. because this type of TB requires stronger microbial medicines that are taken for a much longer duration and also have more adverse effects and also are costly if we compare to the drug-susceptible TB. So in Africa in general, the estimates indicate that we have around 77,000 Africans that are affected by drug resistance each year. And also we have the problem in terms of detection, because a quota of them are treated for this drug resistance. This means that 75% of people affected by this disease are not detected, so are not receiving the care they need. So, but we think that to proper address this drug resistance issue, really we need to make sure that these people that are affected by this disease are adequately addressed with the issue and treated. And for that, the national TB policies must also include this provision of access, and also ensuring that this oral treatment regimen are used to address this disease. And of course, we need also to involve also the partnership with private sector to make sure that this is broadened, and this also will help also to handle this issue in terms of giving treatment.
Thank you very much, Dr. Gasana, for that addition. This next question is coming to you, Dr. Charles Mwansambo. The question is from Elizabeth Atiano from BBC Africa. What impact has Cyclone Freddy had on health emergencies?
Well, I would call it a big impact, because if you may recall, we were here a few weeks ago talking about cholera. And as a country, we put in quite a lot to fight this cholera, and looking at the curve, the epic curve, I mean, it was on its way down. And we even looking at the case fatality ratio too, it was going down significantly. But as you may have heard in my report, with the flooding in the 14 districts, which is half the country, it's washed away a number of homes, plus also a number of toilets and water sources. So that puts us at a potential risk of further waterborne diseases, including, of course, cholera, dysentery, and other diseases that come along with that. So yes, while as we have put in issues to mitigate, but there is that potential risk that we come a week or two today, it might be a different story, but it's my hope that whatever systems we put in place will mitigate and not affect our response. I'll stop there for now.
Thank you very much, Dr. Charles. So let me go back to Patrick Kiwalabi. Are you ready to go live, Patrick? Okay, Ashwin, are you ready to go live?
Yeah, sure. Thank you. Thank you for considering my question. My question is on Cyclone Freddy. Throughout the Cyclone Freddy's 40 days journey, it grabbed the title of the longest regaining tropical cycle ever. My question is, what are the initiative steps taken by WHO Africa to emergency health services in affected African countries? And is special health camps or temporary mobilized hospitals facility available to affected provinces? Thank you.
Thank you, Ashwin. Dr. Fiona Barker. Dr.
Thank you
Fiona?
very Yes. Thank you very much for the question. Indeed, the cyclone impact and duration has been severe. We have had Cyclone Freddy hit some of the countries twice, and majorly the impact has been felt in Madagascar, in Mozambique, and in Malawi. WHO has been working very closely with the countries to try and ensure that there is some level of readiness to be able to respond to the health impact of the cyclone. We did establish a cyclone command center based at our emergency hub in Nairobi to start the process of risk mapping and trying to identify potential impact and mitigation measures with the countries. But as was mentioned by one of the speakers earlier, the extent of the impact is never really known, even though you know that these cyclones are going to happen. And so in this instance, we've had extensive damage. So we have worked with the countries in terms of deployment of technical assistance, technical experts to the countries to support them in conducting assessments of the situation, the damage to health infrastructure, the risks associated with infectious diseases, and how we can ensure we prevent those from happening. Of course, in two of these countries, Malawi and Mozambique, we already had ongoing cholera outbreaks. And so the response there is to see how we can mitigate further spread of these outbreaks and not impact the progress that we had started to see, particularly in the case of Malawi. So technical support, supplies and medicines. We have seen interruption of health service delivery in these locations. So WHO has worked with the countries to quantify the supplies that are needed, and we have had to airlift in some of the instances supplies to support the teams on the ground to provide essential basic health services. We're also working with the countries on ensuring that early warning systems are in place. As with disruption of health service delivery, even the surveillance and reporting systems may be impacted. We have many people displaced and in IDP camps. And in such situations, you need to establish a system where any notifiable disease of concern is quickly reported up the system and that you're able to respond. So this is how we are supporting the countries. In addition, ensuring the continuity of essential health services, ensuring that we set up a mechanism in the interim through mobile teams to locations where displaced people are, that those kinds of health services continue to be provided so that these people in need can be, their needs can be met from a health perspective. So these are some of the areas that we are supporting and working closely with the countries, given the presence we have in all the three countries affected. Thank you.
Thank you very much, Dr. Fiona. Dr. Charles Mwasambo, do you want to weigh in from the country perspective on the impact of the cyclone?
Yes, I mean, whatever Dr. Bracker has mentioned is actually true for Malawi. She's currently with us here in Malawi, though we're not physically in one place. So indeed, for this cyclone, as a country, we'd put some measures in place. We'd prepositioned some supplies even in these affected areas, and the teams came together. We have the National Disaster Preparedness and Response Committee that met and planned, but obviously it was beyond us. I mean, what we prepared for is not what finally ended up with us. So, but I'm glad that with the support of UN organizations, including the World Health Organizations and a number of our partners and non-governmental organizations, we're able to put together a team that is responding. I saw in the Q&A about a question on cholera to say that the cases have gone down despite the cyclone. I mean, this is too early to comment on the cholera projection because the cyclone only happened about a week ago. So we will closely monitor that, but we don't want to see an upward surge of the cases again. We'll do everything possible to stop it, of course, with the support of government and other partners. Thank you very much.
Thank you very much, Dr. Charles. And then this next question is coming to you, Dr. Tiana Baude. The question is from Tony Gabo with CBS FM. There is silent rising cases of COVID-19 in Uganda, but the Ministry of Health seems to be silent on this matter. Dr. Tiano, are you there?
Yes, thank you, Mary, for the question, and good afternoon, colleagues. Thanks for the question. We are not that much aware about any rising situation of COVID-19 cases in Uganda, but we can try to find out a little bit further. But from all of the system, I mean, that we have established here, the surveillance system that we have established and which has been working, I mean, for the past 3 years, you know, we have quite a sensitive way of detecting any rising number of cases in all our 47 countries, and that system can allow us to say maybe this country is in a kind of a situation of concern, or the other one is a kind of in an alert system or in an alert stage, or the other one is in a resurgent system. And from that system, I can confidently say that at the moment, for the past 7 days, our top 10 countries where we have seen, I mean, a rising number of cases are countries like Zambia, Ethiopia, Algeria, Cote d'Ivoire, and other countries. We have those top 10 countries, and Uganda are not part of those ones. But it's a situation that we are really monitoring very closely with all of our member state countries, and I think we have not been, aware of such an increasing number of cases. And just to finish, I think to mention that, after 3 years of the pandemic today, there are some kind of good also response capacities which has been built in countries, you know, to address any type of increasing number or alert of increasing number of cases in all of our countries almost. Thank you, and back to you, Mary.
Thank you, Dr. Baude. And now I go live to Dorcas Wangira from BBC Africa. Dorcas?
Well, good afternoon. Well, my question is based on the latest IPCC report that did mention that there will be increased health emergencies because of climate change, particularly in Africa. Well, diseases like malaria and cholera are widely reported, but I'm curious about plague. Is this a climate-sensitive disease? And what's the situational update, particularly in Madagascar and DRC?
Okay, thank you, Dorcas. Dr. Moeti, do you want to start? And Dr. Fiona could complement.
Yeah, thank you very much. Indeed, I'm not aware, but I would have to think about it, and perhaps Fiona can supplement if plague is climate sensitive or not. I think that that's something that we need to look at. I mean, certainly, in fact, I was going to just say that in looking at the situation of all these disease outbreaks more generally, we need in the health sector to be better connected to the discussions that are going on about climate change, and to be much more proactive in accessing, for example, some of the resources that are being invested in climate change mitigation. Health is one of the sectors that's very significantly affected, and we are intending to work with countries for that, to do this analysis of the vulnerabilities and to be part of the discussions around climate change and the environment at the country level, and very much the global discussions that are going to be taking place at the the Conference of the Parties on Climate Change, so that health is better situated, the resource needs of mitigation, prevention in health are taken better into account, so we do not have the kind of impacts that we've just been discussing in Malawi, Mozambique, etc., without resources to prepare, most importantly, and to respond. So Fiona, perhaps you might want to respond to, yeah.
Dr. Baraka?
Thank you very much. Indeed, its plague is more about endemicity in some locations than climate related. And we do have some countries in the region that have been frequently reporting plague outbreaks, DRC, Madagascar, Congo. And this has been more around seasonal patterns because they usually occur during the hot and rainy season. So it's something that's been happening over the years and less related to the changes in climate. We did, your question around DRC and Madagascar, we did have plague outbreaks last year in Ituri province in the DRC. Over 600 cases and about 15 deaths were reported. But the data currently shows a decreasing trend in terms of cases and deaths. Madagascar also did report an outbreak last year, but a lot of effort made to try and control that outbreak. As you know, it is usually, the reservoir is usually from rats, so it's important around the control measures in the environment and as well as the management of the cases. So just to complement, it is a disease that we do see cases occurring frequently in some of the countries on the continent.
Thank you, Dr. Fiona. And now turning to you for your question live, Catherine from Washington Post. Catherine?
Thank you so much. Please, I would like to ask for an update on the Marburg virus outbreak, please. I think in Equatorial Guinea, I think there's some cases suspected in Cameroon, in Tanzania, anywhere else. Just, how many cases have been confirmed, how many deaths there have been, what actions are being taken to contain it, please, and how seriously the WHO is taking this. Is this something that is, a real emergency, or is this something that is under control, please?
Thank you, Catherine. Dr. Fiona?
So thank you, Catherine, for that question. So to date, in 2023, we have two outbreaks of Marburg, Tanzania and Equatorial Guinea. The Equatorial Guinea outbreak started earlier. We got declaration of the first case on 13th of February. And since then, there have been 9 lab confirmed cases from Equatorial Guinea. There were some deaths that we referred to as probable, but because we were not able to do the testing on those cases, but that's the current count. For Tanzania, as we mentioned earlier, we do have confirmation of cases as of 21st of March, 2 days ago, 8 cases, including 5 deaths. This is still localized to one region, and the investigations are ongoing. In terms of response, as you know, Marburg is a serious disease. It has a high fatality, and there is need. It is highly infectious, so need for speed and effective response. We do not have treatment or vaccine available. So it's important that the control measures around the cases that are identified are implemented. It's a combination of interventions around ensuring you identify the cases early, you isolate and ensure preventive measures for further spread through infection prevention and control in the healthcare facilities or isolation facilities are optimal. So you try to manage the cases with support treatment, but also ensure that the active case search for any additional cases in the communities are concurrently happening. There is also the aspect of the community engagement, ensuring that the risks are communicated to the communities and that they take the necessary preventive measures. So all this together is what we are working with to control the outbreaks. In terms of wider concerns, the outbreak in Tanzania is in Kagera region that borders with 3 countries, Burundi, Rwanda, and Uganda. And so it's important that those countries are on high alert and that they are taking the necessary preventive measures, also ensuring readiness in their countries to be able to manage. We're happy to note that with the efforts last year around the Ebola outbreak in Uganda, most of the countries in the sub-region had rapidly stepped up their readiness capacities, including Tanzania. In terms of lab capacities to detect, and Tanzania was able to do that. There is a mobile lab in Kagera. There is a national lab that can easily test and confirm a diagnosis. So lab capacities, screening at points of entry, and other readiness measures were put in place in the country. So we're optimistic with those capacities that these countries should be able to move speedily. For Equatorial Guinea, Cameroon and Gabon are bordering the affected province, and they have also been, since February, stepping up preventive or readiness measures in their countries. The rapid response teams that have been deployed to the border areas, lab capacity building, and other measures have been taken into account. So with this concerted effort, we should be able to mitigate the risks associated with possible spread. Thank you.
Thank you very much, Dr. Fiona. Dr. Moeti, do you want to weigh in on the Marburg outbreaks in the 2 countries in general?
No, not really. I think just to reinforce the importance of progressively building up the capacities in the countries and being in a state of readiness. I think it speaks to, we're just emerging from a global COVID-19 pandemic, and there are many discussions going on now about how the world needs to be better prepared for disease outbreaks of the magnitude of the COVID-19 pandemic. But we must remember that as part of getting there, we need to be working on improving the capacities of countries to deal with a small, a medium, and a large outbreak. So to me, it speaks to getting countries engaged in the global discussions and to benefit from some of the resources and mechanisms that are being made available at the global level for pandemic preparedness and response. And at the same time, discussions going on about climate change. And we've seen the link between climate change and disease outbreaks. So again, to urge, and we as WHO will support the health sector, the health ministries, and going beyond health, the governments in our countries, to engage in these discussions, negotiations, access to resources around climate change so that they can benefit the needs of preparedness to prevent the health consequences in our countries. That's just what I wanted to add.
Thank you very much, Dr. Moeti, for the addition. And then I come back to you, Dr. Charles. This question is from Lucio Blanco from Spain's International News Agency. According to Africa CDC, the cholera numbers have gone down in Malawi in spite of Cyclone Freddy. what have you done to make that possible? Dr.
Well, there's
Charles
Mwansambo. Thank you very much for that question. There's a lot that we've done as a country, and we're working with our partners, both at UN and a number of non-governmental organizations. We, at the topmost level, the coordination of the cholera response was tasked with the same team that was looking after the COVID response. This is a presidential task force. So in addition to COVID, they're given another responsibility to look after cholera as well. So that helped with coordination. And the president himself launched what is called the Test Say Cholera campaign, which involved engaging communities, right from the religious, the political leaders, the traditional leaders to join the fight. And we've also engaged local councils to go to the communities and deliver the right messages through risk communication and community engagement, door-to-door delivery of chlorination. And some communities have taken it upon themselves to go to the water sources and start giving out chlorine to the communities. So all these interventions with support from our partners are going on. And if you look at the EpiCurve for week 9 to week 10, there was actually a 40% drop, and the curve has continued to go down. But as regards to the Cyclone Freddy, and quite a number of the districts in the south have affected some of these interventions we put in place. So we're just keeping our fingers crossed that we should not see another spike of cholera. And for this campaign, we'd actually put it on hold during this time when we had severe flooding and the mudslides. So we recommenced it again yesterday in the affected districts. So I hope we maintain the gains, but I'm sure together we can make a difference. Thank you.
Thank you very much, Dr. Charles, and congratulations on the progress with the cholera response effort in Malawi. Now we are coming to the end of the press conference for today. I'll go back to our panelists to ask them for their final message. I'm starting with Dr. Njeka. Your final message, please.
No, thank you so much. My final message is that the press, the journalists play an important role. Need to continue to educate our people. People have symptoms, TB symptoms, need to go for testing. They could be having tuberculosis. I think that's very, very important. And also to say to the colleagues, the doctors on the call, we still have a big problem. We have incidents, TB incidents coming down, but a lot of people still continue to die from tuberculosis. There's no reason for that. I know our own cohort in South Africa is a special one with around 60% of people living with HIV. Our TB as 60% is a big problem, but when you look at success rate of TB in KwaZulu-Natal with the highest TB prevalence is the best in the country. It means that even HIV is not a reason why people continue to die from tuberculosis. We need to make effort there, but our politicians must also make sure that living conditions are improved. More than 20% of our patients go through catastrophic costs in many countries that have done this survey. Poverty is really a big problem. Dealing with poverty will help the fight against tuberculosis. Thank you so much.
Thank you very much, Dr. Njeka. And again, congratulations to South Africa on the efforts so far regarding the TB control as we continue to make effort to address the challenges regarding this disease. And finally to you, Dr. Moeti, your final message.
Okay, thank you very much. First, I'd like to thank my fellow panelists. Thank you so much for having joined us in this press conference and shared this very precious information with the journalists and through them with the general public. And I'd like to thank our journalist colleagues as well for the work that you do informing people about health and how to stay healthy and how to have access to treatment when they need it. And then finally, I'd like to express on behalf of my colleagues in WHO our condolences, our sympathy, which I've already done in writing to the countries affected by Cyclone Freddy and the mortality and the devastation that has followed this storm. And just finally to reiterate again, the connection between all this. Thank you, Dr. Njeka, for making the emphasis on living conditions, the social determinants of health, poverty, as factors that drive ill health. If we look at cholera as well, it is generally people in the low social groups that don't have access to safe water and sanitation that are most affected by cholera. So all of these are connected. Living conditions, socioeconomic status, poverty, and climate. So we need in our health response and policies to make the connections so that the resources that we have for dealing with different diseases are also supplemented by other resources that are meant to address these social conditions of people. And I believe if we make those connections, we can be more efficient in using resources that might be going into a global financing facility to deal with a disease, to address particularly people living under different conditions. We need to work, as I said before, very hard on taking on board the issue of climate change and how it affects people. Because if there are extreme weather events, people move because they need water for their cattle, people move because they need water for their survival, and live in very precarious conditions under which then communicable diseases thrive. So our ambition is WHO, is to help our member states. And thank you again, Dr. Njeka, for having made reference to political leadership, politicians and their role in sustaining interest in this and in making decisions about allocation and actions so that we address all of this. So my main message is we have a connection of factors and we have a connection of vulnerabilities that we need to address collectively. And at the end of the day, it's how we address communities, how we speak to people, how we help people to be living in better conditions that we're going to address vulnerabilities to diseases. So thank you, everybody. And let's all work together across sectors, across boundaries. And I finished by saying there are huge opportunities in some of the global discussions that are going on about pandemics and that are going on about climate change that we need to seize as the health sector so that we put in place, we benefit from those resources and continue to improve our interventions in countries. Thank you.
Thank you very much, Dr. Moeti. I would like to say a very big thank you to all of you, Dr. Moeti, Dr. Charles, Dr. Njeka, and all our journalists. Thank you for spreading the message out there. Prevention is always better than definitely response. So let's continue to do the good work to improve the health and well-being of the people of Africa. We have come to the end of the press for today. Have a nice day and see you in 2 weeks.
Thank you. Yes, we can end TB.